So since we were waking up 1 hour later instead of my usual 4:30 or 5 a.m., we got to wake up at 6:30 a.m. Seems like I'm a little more efficient in the morning. So I have a couple minutes, and I wanted to go over our case that we posted yesterday, who's the most beautiful, beautiful young lady. And I think it's like a good case for surgeons to review to kind of understand what's going on with the mouth and the face as we age. And hi, Dr. Harris. So I just want to go over this case that I don't know if you guys saw yesterday we posted. She's the loveliest, sweetest person ever. So if you guys ever get to meet her, you're very lucky. But what I wanted to show specifically is how these two types of surgeries can really impact somebody and change them in such a dramatic way, and kind of what surgeons are missing when they're doing neck lifts and things like that. So we'll start from the lateral view, which you can see here when we're looking at the contours of the neck. A lot of surgeons kind of poorly understand why there's still residual pull in the neck, in the digastric and submandibular gland region. And they think it's because the digastric is hypertrophied or the gland is hypertrophied or ptotic. And realistically, in most cases, that's not the situation. What's happening is the platysma muscle, which you can see on her has a little indentation here as it comes down, has moved forward slightly, and that has come down slightly. So it comes down in this direction and it medializes. What that does is medializes the gland, and then the digastric, which comes this way down to the hyoid and back up to the mastoid, gets a little change in its vector. So realistically, people don't need a big lift to get this back up or to get that gland tucked back in. They just need to be pulled in the right vector and medialized into the scalp, into the neck. So the way to really approach this is not trying to pull as tight as you can in that direction. All you really need to do is release towards the gland, and you have to sling everything up in the same direction as the posterior belly of the digastric muscle. So the posterior belly of the digastric muscle runs from here at the lateral hyoid and goes up into the mastoid tip, where it inserts on the deep portion under the SCM. So that is really what gets rid of that digastric pull that you see in all these conferences that we talk about. And I think it's been poorly understood and poorly explained on how to treat that. So other surgeons would say do a digastric reduction. Realistically, why they have that pleat that comes across is because they pulled a little too horizontally, so too posteriorly rather than vertically in this direction. And you can see this is the actual pull. And when you pull in that direction, you're pulling exactly against this fulcrum. And the fulcrum for the submandibular gland is the same as for the digastric. So they cross in the same exact place, and that's where the ptosis happens. It's actually also exactly where you get a dehiscence in a lot of patients, in the platysma is right around the submandibular gland right there, and it's where the platysma is weakened. So it's our job to really pull against it in this direction, and if you need counter tension, you can pull medially, which is what I did. So the other cool concept here, if you look at this lovely patient, is what I call offloading. Offloading means that if you lift from the cheek, let's say, or from the neck, let's say in this case the cheek, where her cheek came up, the area above it gets offloaded. It doesn't have any pull down anymore. And so you see she gets a brow lift. If you look at the tarsal height over here in the tarsal platform, she got a brow lift just out of lifting the face. So the face came up, took the weight off of the brow, and now the resting tonicity, or the tonic contracture on the brow, works better. So her brow isn't pulling down anymore because there's less weight on it. So we kind of unweighted it. We brought this back up, and the brow went up automatically. So this is a concept that I call offloading, and I'll try to publish about it at some point when I get to it, but you can see what a big difference that makes just around the eyes. And she really didn't need anything done to the eyes. It's already been handled, but you can see how much weight came off of both sides. Tarsal platform improved, and there's just less weight and strain around the eyebrows themselves. Then we look at the mouth. So this is kind of cool. How do you make somebody she's a very happy, sweet person, how do you make somebody who's happy and sweet but looks sad because of the type of aging their body underwent. How do you make it look happy again? This is a very difficult thing to do, because if you do a lip lift on somebody like this and you do a classic design lip lift, you're going to be pulling them centrally more than laterally, and you get an exaggeration of this slope. And the commissure will stay lower than what we call the stomion. The stomion is where the mouth, or the aperture of the mouth, closes. The commissure is this corner out here. And there's different types of relationships between the commissure and the stomion. If you have a commissure lower than stomion, you're predisposed to central lip exaggeration when you do a lip lift. So this patient specifically, when treating her, I lifted more laterally than centrally when we're looking at the incision design, which I have somewhere. And then I did a corner lift. And the corner lift, there's two different types that I do. This one went past the corner to get the weight off of this entire area and the weight off of this area. And you can see how much that changed the vector of that down-pointed commissure on each side. And these are your incisions. So they're really hard to see. This is before lasering, I think. I think we lasered her this day, actually. And these are your corner lifts. So you can see how much weight it took off of each side. And the way you have to design these things is to try to get as much exposure of this lateral vermilion as possible, because it's buried. You want to reveal that. And then you decide, am I going to go past the commissure with my incision or not? In this case, because she had a down point, hi, Dr. Chopra. So in this case, because she had a down point, the incision came down like this, and like an upper blepharoplasty, you get an inflection, an upward inflection. It goes past the commissure, and that way you can actually tilt this upwards. And you can see the degree of rotation has changed. So her downward pull here has now been neutralized. Not entirely. I think it's hard to get it done entirely without cutting all the way across. So we say, okay, this is kind of our limit. This is my limit. I don't think I could have done more than that. But you see it has neutralized her on the side. So I think that itself made just a big difference when you look at the down pull around the mouth. Now, the other option is you could just Photoshop this and not worry about actually doing the surgery. But here you see it's a substantial difference on the down pull of the mouth, which changes the character of the mouth from a sad one to a happy one. And this is her. Like when you see her in person, and if you're ever lucky enough to meet her, you'll see this is her. She's this, she's not like this. So this makes everything kind of look a little down pulled, a little sad, and then here everything is happy, bright, and beautiful. And this actually reflects her much, much better. When you see her, she's really, really a happy, sweet person. So I think the things that we forget to talk about with patients is we just talk about making people look younger, and this isn't always the case with patients like this. She doesn't need to be better looking, but I think a little bit of character change was perfect for her. And the thing that I talk about a lot when doing lip lifts and facelifts is character change, making someone look softer, making them look more pleasant. With the mouth, we actually talk about sexuality and sensuality. It's the one procedure for the face that you can talk about sexuality, making someone sexier and restoring their sexiness. And this is something that surgeons don't talk about unless they're doing body stuff. In the face, it exists too. And the main area where we talk about sensuality is around the mouth. And restoring sensuality is really important, just like restoring someone's fertility, I'd say. And when you look at the mouth here, you can see there's two areas on the face that are white and bright, and that's the eyes and the mouth. And those are your areas of communication. Lots of people have talked about that. That's where the attention is drawn when you're talking to somebody. And then there's one area which is an entry into the face, I'd say, and that's the area of sexuality and sensuality, and that's the mouth. When the mouth has darkness here and you're looking inside and seeing dark or seeing lower teeth, you lose a lot of that, and it makes somebody look a little bit older, and they lose a little bit of their sexiness. And so for her, she's so beautiful, we just wanted to restore that sexiness. And that's what this does, is going and restoring the sexiness. Now, you could just go put longer teeth there, but that doesn't really add to anything in terms of sexiness. It just makes somebody have brighter teeth, and you've added long teeth to kind of a mopey